Okay, I think we'll get started. Thanks everyone so much for joining, and thanks to IAS-USA for hosting this dialogue. My name is Meredith Clement. I am an assistant professor at Louisiana State University Health Sciences Center here in New Orleans. And I'm here today with Dr. Susanna Naggie, who is also trained in infectious diseases. She's an associate professor at Duke University School of Medicine. Dr. Naggie is an expert in HIV and viral hepatitis, and my clinical and research focus is in the prevention of HIV and STDs. And so today, the title of our dialogue is When the Going Gets Tough, the Tough Keep Going, the impact of the COVID-19 pandemic on hepatitis C and STI testing and care. So before we get started, I have just a few housekeeping items to go over. We're really happy to take any questions, but please do use the Q&A button to ask questions, and keep in mind that the chat feature has been disabled. And so the way we'll try to make this work is about 40 minutes of discussion between Susanna and myself. But again, please ask any questions, especially relevant questions as they come up, and we'll try to get to those relevant questions. We may save some of the other less relevant questions for the end, but if you're thinking that you have that question, other people probably have that question too. So please, we would love to take questions. And then remember that this dialogue is not available for CME, but it will be available by webcast and podcast after the broadcast. And then a final reminder is that, as we all know, things are changing very rapidly with respect to the epi and research landscape of COVID-19. And so just keep in mind that the information and updates we're sharing today will quickly become a little outdated. So most of you are probably following the numbers pretty closely, but just to sort of think about where we are this day and time, November 23rd, I just want to take a quick look of the numbers. So as of this morning, according to the New York Times and the COVID tracking project in the United States, we have more than 12.3 million people infected. We have roughly 84,000 people hospitalized, and we've had more than 256,000 deaths attributed to COVID-19. And then I think probably also many of you are aware that late last week, the CDC recommended against any Thanksgiving gathering or traveling plans outside of the people in your immediate household. And so kind of we know, I guess, with the numbers where they are and the projected numbers, the outlook for the next few months is particularly grim. But there is light at the end of the tunnel, we think. And Dr. Naggie, do you want to go over some of kind of the highlights with respect to the vaccine studies that we've seen published or press release recently?
No, absolutely. And I do agree with you. I think there's been the trickling of good news. And I think here really over the past few weeks, we've heard some really fantastic news that I think is something that we should all be very excited about. And I do think it's important to talk about because, I think there's a lot of concern for folks out there. We talk about how long it normally takes for vaccine trials to get through the typical path through FDA approval. And I think there's been a lot of concern of how could this happen so quickly and yet be safe. And I think it's really important to talk about the fact that the FDA has always had different mechanisms for moving particular drugs or devices through more quickly if there's an urgent need. And the EUA process is a process that I think many of us have never had to utilize during our lifetime. And so it's a bit of a different approach to accelerating discovery, getting things very quickly into the clinic when there is a public health emergency. And as we know, the Secretary of HHS declared the pandemic a public health emergency actually in January of 2020. I can't believe that we have almost come a full year. And, I think there was much hope that we would see vaccines available by the end of 2020. And in fact, it sounds like we may just meet that deadline with at least one vaccine. So, and we've certainly seen a lot of movement. So I'll run through these really quickly. And then if folks have questions, we can certainly come back to them. And I was also going to quickly run through I do think the FDA also, I think probably because of concern and just to provide some additional guidance in addition to the guidance that the FDA put out for licensing and approval for a vaccine is they also put out guidance around what does a company need to bring forward to get an EUA, or to at least be reviewed for an EUA. So I'll go through that quickly, because we do know, per the press release from Pfizer, that they met those criteria to submit for the EUA, which they did. And we now know that the advisory committee will meet on December 10th. And so we expect to hear of an approval probably by the end of the year, given that meeting on December 10th, right? So we'll go to the first one. So Pfizer was the first one where we initially heard some efficacy data, and then an update to that efficacy data once they got some additional cases. So this is an mRNA-based vaccine. This is in phase 3 study. And as I mentioned, their efficacy report, just I think so it was last week, was 95% efficacy. And that was based on 170 confirmed COVID cases. And of those 170 confirmed COVID cases, in over, I believe it was 43,000 participants who have received the vaccine, which is, again, a 2-shot vaccine series over a month period, is 162 of those cases in the placebo arm, and 8 of them were in the vaccination arm. So it's, I mean, very impressive, and does in fact meet the requirement or the criteria for EUA, which was that your vaccine has over 50% efficacy. So they certainly check that box, right? The other thing is that the FDA says that they wanted for the EUA submission to have at least 5 severe cases of COVID in the placebo arm. And in this case, they in fact had 10 severe cases of COVID in the study, and 9 of them were in the placebo arm and 1 was in the vaccine arm. So again, showing that you don't just prevent the infection, but you in fact appear, although small numbers at this point, appear to also decrease the severity of disease if someone does in fact develop the infection. So I think these are fantastic news. And the other kind of box they have to check is having at least 2 months of follow-up from completing the vaccine series. And that is the threshold that they crossed just recently, and that is why they submitted their packet to the FDA for EUA. And again, we'll hear about that on December 10th. The other one that we have been following very closely, of course, is the Moderna vaccine. This is also an mRNA-based vaccine. They also have a phase 3 trial called the Covet trial. And their interim data, again, released per their DSMB last week, was, again, 94.5% efficacy. I mean, honestly, as healthcare providers, as I mentioned, as citizens, as parents and spouses, I mean, this is really fantastic news. I think many of us were afraid to hope for an efficacy this high. And so I think this is very exciting. Again, they had 95 cases, 90 of them in the placebo arm, 5 in the vaccine arm, and also had 11 cases of severe COVID, all of which occurred in the placebo arm. So again, just kind of highlighting checking those different boxes. And I think Moderna still has some time, presumably for follow-up, to be able to hit that final 2-month follow-up after the vaccine series. And then maybe quickly, I'll go to the AstraZeneca, which we know is the other one that we are all following very closely. Just reported out today. We have very little data on this one so far. Over 23,000 people have been vaccinated across the globe, and 131 cases of COVID. They reported out some interesting differences in efficacy. So overall, 70%. But if they look at this, they're actually testing 2 dosing strategies. One is looking at the kind of high dose, also a 2-dose series. All of these are 2-dose series. A high dose times 2. And then they're looking at a half dose followed by a high dose. And interestingly, there's a very different efficacy in these 2 arms so far. I don't think we fully understand what that means. 62% when you get the full dose times 2, and 90% efficacy when you get the half dose followed by the full dose. So I think that's data that's still emerging, I would say. But I think, it sounds like Pfizer's going to, have its day in terms of hearing. In terms of the committee, advisory committee hearing them out on the 10th, that will be, I think it's really important for folks to know that will be a public, that at least will be a public part of that hearing. So people can, not hearing, but that meeting, so people can certainly log in. And then for folks who follow this really closely, the FDA will provide the meeting materials 2 days in advance. So you can certainly log in and grab that material and look at what they'll be reviewing at that meeting. So, I think a lot to look forward to over the next few weeks.
Yeah, and Susanna, we already have a question from our dear friend Chuck Hicks. There are no precedents for mRNA vaccines in humans, and he's exactly right. This is a totally new technology. Do you think there are any concerns with this approach to vaccination? And there are requirements for 2 months of safety data, I believe. Do you have any other concerns? It'll all be reviewed.
I think it's as with any novel approach to a therapy, you certainly want to ensure that there are the appropriate checks and balances and ensuring that there is appropriate safety. I mean, I personally don't have a significant concern about the mRNA approach myself. I actually think it's a really exciting approach, and I think it's very interesting that it just so happened that this technology was coming forward right in time for this urgent need for COVID vaccines to be developed. And here we are with those 2 mRNA-based vaccines moving forward very quickly and very promising. So I think it's critical, though, again, because it's a novel approach to vaccination, is to make sure that we see those safety data. And I do have full confidence that we'll see that data, and that will continue to emerge. I mean, I think the other thing that's really important to understand per the EUA is that for any one dose per the EUA, because this continues even after an EUA to be an investigational vaccine, is that the FDA will require that those companies track the safety in long term in terms of any adverse events, whether short or long term. So we'll learn this as we go along, but I can tell you that I think it's super exciting, this new approach to vaccination, and I for one am excited to see where the data leads us.
Well, and Susanna, I agree. It's so remarkable. And I just want to highlight one thing. So with the really fantastic efficacy in these studies, Dr. Fauci makes the point that he's hopeful that this high efficacy will overcome some of the vaccine hesitancy that we've seen kind of when the population has been surveyed. And, there's kind of this culture of medical mistrust right now among a lot of the American public. And so, if a vaccine was maybe 50 or 60% efficacious, people may not be as willing to get it. But now we know with these really exciting numbers, thinking that hopefully that will overcome some of the hesitancy on the part of the public.
I think that's going to be huge, actually. I think we know that in order to really have an impact on the pandemic, we need to vaccinate well above 50, 60, 70% of the population, right? Now, I think it may be interesting, and I'm hopeful this is true. As healthcare workers, we will be leading the way. In terms of the prioritization, right? This is not going to be accessible to the general public for many, many months, right? We know that. We know in terms of the prioritization, the prioritization recommendations have been released by the CDC. All state HHS groups are putting these forward, and so I do think that we will see healthcare workers, particularly those at the greatest risk, taking care of people with COVID, are going to be in the front line of getting these vaccines. And I think we can show the public that this is something that we believe in. And I hope that in that they will understand that if we can trust the vaccine, so can they. But I do agree with you that there's going to have to be a lot of education out there about why these things were able to move so quickly, and that there was not cutting of corners. But that there are ways that, believe it or not, the federal government can do things quickly when it's absolutely necessary.
Right, exactly. And so I think we could spend the whole time talking about the ethics of how you roll out these vaccines. But just for the sake of time, just a couple of other updates. So last week, it was announced, or there was EUA status given by the FDA to the Sierra Covid19 all-in-one test kit. And so just to sort of briefly mention that, it's a molecular test, I think, as probably most people know. It's probably going to be available with a prescription only, but also in clinics, doctors' offices, urgent cares. It has pretty good test characteristics. So it's about 94% sensitive and 98% specific, but those test characteristics were determined in a really small patient population. So there are other studies, kind of larger clinical studies, that are ongoing in Florida. But we expect it to be available to the general public in 2021. And then just kind of on the topic of testing, I did want to touch on, because the holidays are coming up, this kind of moved by a lot of our friends and family to get tested in order to go celebrate with family members. And I mentioned the CDC guidance, or rather really a warning against kind of these large family gatherings or gatherings with people outside of your households. And so, you know, I've had friends and family talk to me about, can I just get tested before I celebrate Thanksgiving? And I think we just all need to be aware of the limitations of that approach, in that, you know, certainly you could already be on your way to developing an infection, but just not test positive yet. You could be exposed after you test or after you get your test results back. And so just to kind of, I guess, in what, echoing again, Dr. Fauci, you know, we have a vaccine, there's a light at the end of the tunnel, the cavalry is coming, but we can't put our weapons down yet, right? We need to stay vigilant. We need to exercise caution. We as providers and everyone on this call needs to continue to kind of counsel our friends and family that we're not there yet. And especially, I think there's a lot of fear about what we're going to see in kind of the December, January months, when people are, you know, there's more gathering indoors, it's colder outside, and all these things. So kind of just staying strong, remaining vigilant, exercising caution. Yeah. And so on that topic of kind of keep going when the going gets tough, which is the title of our talk, Susanna, I'd like to ask you about some of the challenges we might be seeing with respect to hepatitis C and B testing and treatment, kind of in the context of the COVID-19 pandemic. So kind of getting into what we said we were going to talk about during the hour, now that we're 15 minutes in.
No, I mean, look, I think we have a lot of providers on this program, and I think we all know exactly what's happened for our patients when this all started, right? So when it started, and I think this was true across the country, obviously across the world, is that there was a lot of concern about how to see patients safely. Patients were concerned about coming into their providers' offices, coming into clinics and hospital-based clinics, or coming in for their mammograms, coming in for their liver cancer screening. And so there was a big move to either cancel things, delay them, postpone them, or to switch over to kind of telehealth visits. And I think we all really, it was really great to see how quickly health systems were able to pivot to telehealth, and to whether by telephone or by virtual. This was really something that was amazing to see happen. And I think there were so many positives to that, right? However, in that positive of really being dynamic and switching to virtual care, I think what we didn't see was at the same time the consideration. I think one, as many of us, I don't think ever would have dreamed that we would be almost a year into this and having this conversation, to be honest with you. Or maybe I'll just say that I was not one of those people who had that amazing level of foresight. So, I think we all thought it's probably going to be a couple of months, we'll postpone. And then a couple of months came and went, and we realized, oh my gosh, we need to figure out how to actually get people in. So we could still do virtual care, but we really need to figure out, how do we get them in for their mammograms, for their liver cancer screening, for their hepatitis C tests? How do we get them in for their blood tests? And I think we actually, the American Association for the Study of Liver Disease meeting just finished virtually, which actually was a huge success. And we saw a number of presentations showing exactly this thing, which is, when the pandemic hit in March, April, and May, things shut down. And with that shutdown, we saw a significant, and it's like a drop off of a cliff, a significant decrease in HCV tests, hepatitis B tests, HIV tests, hepatitis B vaccination series being completed, and prescriptions for DAAs, right? So, and we know, although this was not presented, but we've all talked about how we need to look at this, HCC screenings being delayed and things like that, right? So, those data also showed that those numbers are starting to come up again. And my guess is that's a conversion, one, to more in-person visits overall, but also, at least in my clinic, we've continued to kind of give patients an option, but to try to do this as a hybrid approach, right? So bringing them in to get their lab visits, because we clearly saw a significant impact in all of these really key metrics regarding testing and treatment and screening. And the biggest issue for us is, the WHO has very clear timelines for every country. And in fact, those have been kind of transmitted down to every state in the United States for meeting the goals to achieve HCV elimination. And this is a pretty big setback for many of our states, and certainly for the United States as a whole, in achieving that.
Yeah, and I was looking at our hospital. I practice at University Medical Center in New Orleans, which is the safety net hospital in downtown New Orleans, and we have a task force dedicated to HIV and Hep C testing in the ER, the opt-out approach, and in our clinics. And so we follow those numbers pretty closely, and our hepatitis C testing rate is usually 600 or so tests per month. But we saw a marked decline kind of March, April, down to 200 tests a month. And actually the percent positivity increased from about 10% to 20%. So making us think, we were probably missing some, right? And so I'm happy to report that in the most recent months, we're back up even higher. So 800 or so tests. And kind of back down to our normal test positivity rate. So, we saw this firsthand in New Orleans.
It's interesting that you say that, because one of the presentations, and I think this is where you really get to, and I'd be curious to hear how you all do that, because one of the papers that came, or abstracts that came out of Rush, they have in their EMR, they have a flag. And what they found was that there was a cliff, as I mentioned, for Hep C testing in their clinics, but in their ED, it remained pretty stable. So it's very interesting to see differences between, right, in the ED, people are still coming in. And we know that there were less strokes, less heart attacks. But when someone got there, it seemed because of the this had been kind of embedded already in the practice in the ED, they did not see that take as much of a hit. What they saw was those clinics where I think there was a big shift away from in-person care. But so what about in terms of STI, other STI? I say other STIs. For you all, I mean, Hep C and Hep C testing in particular, and HIV testing and EDs and things have become very ingrained. But what about other STIs?
Yeah, so I think a number of challenges, and you just were talking about some of the rates. So they track obviously chlamydia and gonorrhea. And so at the presentation, the conference, that CDC STD prevention conference in September, they did discuss kind of some of the numbers of gonorrhea, reported cases of gonorrhea and chlamydia. So back in January, February, kind of when you look at the rates in 2020 compared to 2019, we were about on par with where we were a year prior. And then there was just a pretty substantial decline March, April, May. And it was interesting what data was presented. And all this was presented kind of with the caveat that the 2019 and 2020 numbers are in no way finalized. But what they saw is they kind of looked at projections and gave gonorrhea as an example. But so in April of 2020, we were anticipated to have around 54,000 reported cases of gonorrhea, and what was actually reported was just a little above 26,000. So that there was like this estimated case deficit of 27,000 cases of gonorrhea. And so now in the recent months, things have picked back up again, and they made the point, is this a backlog, or are we really seeing these kind of pre-pandemic rates? And I just you asked about the challenges. I do want to go back for a minute and just talk, because maybe a lot of people on the call are familiar with the fact that 2008 to 2012, we were seeing a lot of funding cuts to STD clinics. 10% of STD clinics closed as a result of those funding clinics, and even in a result of those funding declines. And then even in the past few years, 50% of STD clinics have reported that they have seen funding cuts. And so I think you take this public health infrastructure that's already very fragile and fragmented, and you add a pandemic on top of that, and you really have a public health crisis. So it's been really challenging, I think, across the country to keep up. And David Harvey, who is the executive director of the National Coalition of STD Directors, he presented survey findings from STD clinics across the country. This was also at the STD prevention conference back in September. But what they showed was when they surveyed STD clinics across the country in June, the respondents said that 78% of their STD workforce had been redeployed to COVID-19 efforts. And so you think about like disease intervention specialist officers who are trained to do contact tracing for STDs are now being redeployed to do contact tracing for COVID-19. And of course, it's great we had that availability, but people are probably still having sex and there are probably still STDs that need to be diagnosed and treated. And so, you know, we also know one of the challenges, kind of what you were alluding to, Susanna, is just dealing with clinic closures, reduced clinic hours. Here, what we were closed for a short while. I know in New York, they had, I think they just only had one STD clinic up and running for a while. One of the other findings from that survey I just mentioned back in March is that 83% of STD clinics across the country were deferring services, and half really said they couldn't maintain their caseloads. So, you know, not only is COVID-19 really terrible for causing its own disease, but when it kind of soaks up these other resources, we face challenges elsewhere, you know, with respect to hepatitis C, hepatitis B, and STDs. The other issue I want to talk about, and I could talk about this more later, but just a lack of availability of testing and test kits. And then finally, some drug shortages that may or may not have been a problem, but at least the FDA for a while, and I believe still is, reporting shortages of azithromycin.
Oh, geez. I hope that's not because people were using it for COVID.
You know, well, to be totally fair, I think when, at least in New Orleans, when we started seeing all these cases, our frontline providers didn't know whether they should be treating concomitantly for community-acquired pneumonia. So I think that was one of the big, and we don't even have to go into the hydroxychloroquine azithromycin fiasco, but I think that was one of the big concerns, and I probably attributed to the azithromycin drug shortages. My impression is that, and I'd be interested to know if anyone kind of on the call has seen azithromycin shortages, but these have been kind of local and not national shortages that have caused major problems. And so, Susanna, we have a question. Is there an opportunity to catch up by linking or adding hepatitis C antibody testing to COVID testing or COVID vaccination?
You know, I think that is a fantastic question. I was actually on a post AASOD kind of conference discussing some of the, and really highlighting some of these issues. And a very similar question came up, which was, I think we've seen, in fact, I think in many health systems, this approach to understand the seroprevalence of COVID antibodies and pretty broad COVID testing, antibody testing across health systems. And, you know, we now have a recommendation that HCV, you know, should have universal screening. And so I think there are some opportunities. I think it's a really great idea. It's a great thought. I think that what I worry about is, you know, selling this as very important. And as you know, we've had a hard time really getting people to pick up and carry the concept of HCV testing is really important. And I think this is an area where potentially we could do something very creative in terms of the additional serologic testing that's going on right now. There's actually a question that just came in as well, Meredith, that says, have you guys done telemed visits followed by sending at-home test kits for STDs? We've considered it, but we use Quest for Labs and they weren't familiar with those in our areas. And this kind of gets to exactly how are you managing this? I mean, this is the reality. And what approaches have you managed in your clinics to kind of address this? And I'm happy to kind of talk about what we've done in the Hep C area, but maybe how are you guys dealing with this? I think that's a great question in terms of the home testing kits.
Yeah, so we have an STD clinic that's operated. It's a shared partnership between LSU and Crescent Care, which is our federally qualified health center. And so we did close for a brief period of time. You might recall that New Orleans got hit really hard very early, kind of in March and April, had actually one of the steepest curves and one of the highest mortality rates in the world. And so we were closed during that initial phase, but opened back up relatively quickly. And kind of, I think, Susanna, you mentioned a hybrid approach. That's one thing we tried to do. So trying to talk to our patients, do a lot of the intake and collect history over the phone. Even, you know, patients are already have arrived to our clinic, but we'll call and they'll sit in their cars and give their history to us, just to kind of minimize that face-to-face encounter time, which makes everyone feel more comfortable. And then kind of prioritizing who really needs to be seen in clinic, but certainly trying to maintain testing as best we can. And then of course, treatment, we have not had to defer to oral regimens. And I can talk about some of the CDC Dear Colleague letters in a minute, but we fortunately have been able to kind of maintain giving injections in the clinic and seeing patients in person for treatment. I will talk for a minute about kind of the mail-in test kits, because I think that came up. So there are a lot of different platforms for doing mail-in testing. So people may be familiar with NERCs. They're a big company that do prep, mail prep, and contraceptive services. There's, I think it's My Lab Box. There's a company called Lemonade, and Molecular Testing Laboratory. So there's a number of these kind of services. I think the biggest challenge with a lot of these are patient payments, because a lot of them don't take insurance. NERCs, I am told, does accept Medicaid, but only in certain states. I think it's California, Texas, and Illinois. So some of these testing, you can go online and search, but some of them are rather expensive, in the kind of hundreds of dollars, which is generally not affordable for a lot of our patient population. And then it's hard. Sometimes they need physician orders, sometimes they don't. But if you have a physician involved, there's a question of reimbursement comes up. So there are challenges related to payments. I wanted to find, I think it's Molecular Testing Labs, that's a Vancouver-based, Vancouver, Washington, actually, based laboratory. And they are the ones who are, I don't want to say endorsed by the CDC, but the CDC on their website online talks about this company in particular for mail-in STD testing. And you do have to have a physician to order it, but it is approved by most insurances, and it's CLIA licensed. So I think these companies are being used. I saw some statistics like this one company in particular has doubled the rates of mail-in order requests that they are receiving from 2019 to 2020. So they are being used. I think they can be useful in certain settings, but I think there are challenges related to them. And then I know that we had a question kind of before the Q&A we're seeing right now about the acceptability, but there was a Cochrane review in 2015 that patients actually really referred the privacy and the simplicity and the security of this type of these mail-in services and these kind of self-collection of swabs. And we know that self-collection of swabs are generally thought to be just as reliable as provider collected. So anyway, I don't know if you had a chance to browse the other questions while I was talking, Susanna. I don't know if
yeah, no, I think they're actually great. These are great questions, and I think I can probably address them all in one fell swoop, because they're actually related. So one is that someone mentioned that in Canada they're using dried blood spot testing to try to capture multiple communicable diseases, and this is definitely, I mean, I think I've seen a number of actually research grants proposing this method. I think it actually makes a ton of sense, because, right, again, it gets you the home testing. Participants can do that in DBS at home, send it in, and then you can actually monitor these. So I think it's a great approach. But I think the other two questions come in is like, so how do you manage patients with hepatitis C and you know, have people just kind of stop treating? And I think there are some people who kind of said, look, it's a chronic disease and it's a chronic infection, and whether it's delayed for 6 months, what's the big deal? But well, you know me, I'm a zealot, so no better time to treat Hep C than the present. So, you know, I think what I would say is this pandemic happened in the setting of HCV DAA therapies that was primed to go to a telehealth or virtual approach to treatment. And the reason I say that is, the AASLD guidelines came out recently with an update of a kind of streamlined approach to treatment that does not require frequent testing, frequent monitoring, because we have some data to actually show that kind of more kind of minimal monitoring approaches can work. But also because we now have a lot of safety data with these regimens, and many of us feel quite confident. And we've been on the guidelines, you've seen them kind of slowly working away from the idea of testing labs every 4 weeks and things like that. So in addition, right, we have now 2 pan-genotypic regimens. So the concept of, do you even need genotyping? And these are very safe regimens, and as long as they're used in the appropriate patient population. So I would say that that is exactly what we have done, is we've essentially switched to a fully virtual telehealth approach to starting people on DAA therapies. And then we do have them come in, if they haven't had any labs done, then we do have them come in as what I like to call a lab and leave visit. So basically, a lot of the way that I've done my HCV care is I have a phone call or a virtual care call with my patient, and we go through the conversation. We talk about what is needed. We talk about how this is going to work in terms of receiving the medications in the mail, et cetera. And then we get the drug out to them in the mail. If they need to come in for a visit, we have them do what we call a lab and leave, where they literally drop into the lab, walk in the door, get their blood drawn and leave. And so they feel much safer about that limited contact approach. And I have not required my patients to come in for frequent monitoring. So this gets to the Minman study, and I'm sure many of you heard about this. I mean, really a phenomenal study. So the Minman study was just presented as an oral presentation by Sunil Solomon from Johns Hopkins last week at AASLD. And this was a study that was run by the ACTG and really took this approach of, we know that these drugs are safe. In this case, the regimen was sofosbuvir velpatasvir, right, a pan-genotypic regimen. It's safe in people who have CKD or end-stage renal disease. It's safe in people who have decompensated liver disease. And essentially, this was a single-arm study, so there was no control arm here. But participants were essentially, they did have baseline labs, but they did not have baseline genotyping, and they were given the entire 12-week supply of drugs at the same time. And then they came back at around the SVR12 visit. So they didn't come back for 24 weeks. They were not seen again in person. There were no safety lab checks or anything like that. There was one check-in at week 4 on drug to check in on adherence via SMS or texting. And then there was a follow-up visit, or a follow-up text 2 weeks prior to their SVR12 visit. And that is it. Right? So no frequent lab checks, nothing like that. And I do think that it's actually interesting that the AASLD had already moved to a simplification treatment strategy before the Minman results were presented. And I do think that they fully support this. So we've done this now for months, several months. I'd say we probably started really getting to it. As I said, when we started shutting things down, we thought initially it would just be a delay. Once it had gone on for a couple of months, we realized this is no delay. And then we began getting people back in for therapy via telehealth visits. So I do think that there's plenty of data now to support the safety of this approach. And I would certainly encourage folks to consider that.
Yeah, I had sort of this natural experiment, right? With this, when COVID happened, you may be aware that in Louisiana, we have this kind of Netflix or subscription plan, but it really has made treating hepatitis C so easy for us. And it's really, really phenomenal. But you saw a patient once, you were getting in the process of getting labs, and then you didn't see the patient again for several months. And so, but anyway, just kind of a word on the program we have here, because it's been so phenomenal in making treatment decisions for us. And sorry, I'm kind of like Mike Pence over here.
When that happens. Well, I was going to say, I failed to mention that the overall SVR for the Minman study was 95%.
Yeah.
And that is really phenomenal. This was 400 people enrolled across the globe. And in fact, the majority of patients were enrolled from outside the United States. And I do think it raises, so someone actually, again, on this session that I was on post at AASLD, someone raised this exact question about Louisiana because of the Netflix model, which I just think is fantastic. And I think the leadership around that for the state was totally dead on. And because the question has come up now because of Minman and several other studies is, do you even need to bring people back for SVR12? Do you know what I mean? Particularly in a Netflix model approach where you are trying to get at some of those highest risk folks. Ideally you have enough data to say, just give them the bottles and say, just take these pills and you have a 95% chance of cure. And as far as we're concerned, that's about as good as you're going to get. So I think these are real questions that, yeah.
Well, I think that approach makes sense for a lot of patients who maybe have challenges in coming back to clinic are kind of the patients that we would think are highest risk with ongoing drug use of transmitting HIV or Hep C forward, right? And so they're the most important patients to treat right now. Susanna, your friend Jules wants to know, when will we be able to treat hepatitis C in pregnant women?
Yeah, I think this is, Jules always has great questions. So, and this is another one. I think, look, we are getting there. Catherine Chappell, who is leading the efforts in getting gathering that data for the safety of treating pregnant women and doing those early phase studies. And I will also say that there's a move to hopefully get this through on a much larger scale through NIAID supported networks to really gather that data to make sure that we can do this safely. But I think this is a critical, in many ways, pregnant women are essentially the last population where we have not been able to make that move. And I think we have gotten access for so many other populations that this has got to be a priority. And it certainly is for many of us. And I think Catherine has been a great leader in trying to push that along.
Okay, and I don't think we have any open questions right now. I do just kind of want to circle back. I mentioned the Dear Colleague letters that have gone out. I think many of us are aware of some of the limitations, and I tried to touch on those briefly a second ago, but with respect to STD testing and treatment. But so the CDC has issued a series of these letters to providers to kind of keep them informed on best practices or kind of what they think we probably should be doing in the setting of the limitations of the COVID pandemic. And so there were 3 letters that went out, the first in April, another in May, and then another in September. And so I kind of wanted to review those quickly in case people had not seen those and kind of answer any questions that might come up. Because, it's different times and we're kind of at the mercy of kind of what COVID's doing in these clinic closures. But so the first letter that they sent out in April had asked us to, when it came to screening, that when needed, we could defer asymptomatic screening in routine, just with routine screening visits until the emergency response was over, but to please keep in mind some specific populations that we shouldn't neglect. So those with STD symptoms, of course, they're going to be symptomatic. Those who are not symptomatic but have a contact, an STD contact, should also be tested. And then, of course, any individuals at risk for complications. So women who have vaginal discharge or abdominal pain, you're concerned about PID. Pregnant women with syphilis, you should always try to see. And then individuals with symptoms concerning for neurosyphilis, you always want to get those folks in, try to see them, test them. And of course, I think we all know that penicillin is the only treatment we should be using in pregnant women with syphilis. The other recommendation that came out in the April letter was that if clinics aren't seeing people in person, then form partnerships with other clinics who are. So we've done some of that. I mentioned kind of our partnership, the way our STD clinic in Louisiana or in New Orleans is formed. It's already a partnership between the Federally Qualified Health Center and our academic institution. And so we've stayed, for the most part, open to see patients, whereas the FQHC and some of the other local clinics have only been seeing telemedicine. So, if there's a patient who they talk to on the phone or see through a virtual visit, if there's a concern for that person needs testing, they'll send them to us to actually come in and have that in-person testing. So I think those partnerships are especially important in these times when other clinics may be closed or just have have these limitations, related to telehealth or telemedicine. And then the CDC also kind of outlined these syndromes that should be managed by phone or telehealth visits. And I actually printed this little cheat sheet out. It's from the California Prevention Training Center, but if anybody wants to go online and download it, it really nicely just gives kind of what the preferred regimens are when you can treat with injection medications and when you need to use orals only. But it kind of classifies these syndromes. So like the proctitis syndrome, the genital ulcer disease syndrome, the vaginal discharge syndrome, and kind of what you should be thinking about. Should you be ordering tests in those situations, and what treatments would be preferred, and what you might have to resort to if there are clinic closures. And then the May letter from the CDC really kind of said, hey, we do really appreciate the idea of expedited partner therapy, or EPT, as a harm reduction approach. And for anybody who doesn't know what that is, it's, I'm the provider, I see someone who I diagnosed with an STD, and I offer to treat their partner without seeing the partner or even talking to the partner. And so I either provide a prescription directly to the partner, or I hand over the medicine to the patient to deliver themselves to the partner. And so I think that's an approach that we should be using aggressively, or at least we should be talking to our patients about partner notification very aggressively. But the May letter did kind of say, hey guys, maybe don't use this for syphilis. There's lots of concerns that probably should be addressed in person, or at least by phone or telemedicine when it comes to syphilis. Especially kind of among MSM or other populations that are at higher risk for HIV, they need to be assessed and tested for other things. So in the setting of syphilis, please avoid EPT. And then finally, the September letter addressed the lack of testing kits that we're seeing. And so many of you know there are shortages of gonorrhea and chlamydia testing. Our clinic has had a few times where we were running really low on the urine gnat testing. And so we had to start doing urethral swabs for men. And at this point, all the men coming into our clinic, they know better. They know that they shouldn't have to do that. So they really weren't pleased. But I think centers across the country are seeing shortages in these testing kits. And so what the CDC recommended in this most recent September letter is that we do test certain populations when we can. So for asymptomatic women, especially if they're pregnant or they're less than 25 or greater than 25 with risk factors, that they should do the vaginal swab for gonorrhea, chlamydia, gnat testing. For MSM, we should prioritize extragenital testing and above urine testing. And actually, if you're very limited, do rectal tests above even pharyngeal samples. And then for men with symptoms of urethritis, what they suggested, and I think a lot of STD clinics actually have the capacity to do, is methylene blue or gram staining to look for dipococci, and then treat for gonorrhea accordingly. And that approach really does have a lot of sensitivity and specificity in men with discharge. And then finally, for women with cervicitis or PID symptoms and men with proctitis, those folks should really be treated empirically, but certainly test if you have testing available. And then the empiric treatment of contacts, which I just sort of touched on. And you can forego testing in those situations if you're really limited with respect to the test kits.
So, I mean, I think it's great to, actually, as you're talking, it raises some things. So one is, I'd say just it's 5:48 on the East Coast. So folks can feel free to put questions in, because we're kind of in the Q&A phase, and we're happy to take more questions as they come. But if you guys don't put in questions, then we're going to keep on talking. But it did raise this, as you talk through this, we've talked about how as clinicians and as patients, we've all had to be creative about making sure that we kind of begin to just move forward and make sure healthcare is moving forward, right, in the pandemic. But I do think some of the things that you raised, which is you have to also, in addition to just kind of going to telehealth or thinking about lab and leave visits and doing some of the other things that we've done to decrease to kind of risk mitigation, right? Not using the waiting rooms, calling people in from their car. I think there are some other things that probably need to be done that are very efficient. Kind of as you mentioned, like just treating partners or treating contacts, maybe not the way we would always do it, because there are some dramatic changes we have to make in response to the pandemic. And as you know, we have heard, and I think it's horrendous, because you look at the numbers and the mortality in the setting of the pandemic related to opioid overdoses is on track right now for 2020 to be the highest it's been, I think, ever. And this has been very, very difficult to kind of wrap your head around. And I think some people think that it's just increased usage, but I think it's probably not that simple. And what several studies have now suggested, and the AMA kind of put out a very urgent letter to providers, is that when with these shutdowns, with the conversion to telehealth or virtual care, that may not be, in some ways it's opened up access for some groups, but it also has caused significant isolation. And for a number of our patients with addiction, kind of getting in, and particularly because of the rules and requirements around a provider being able to see someone for addiction for the first time, being able to write that prescription, right, for buprenorphine therapy for the first time, the rules are quite tight. And I think if we continue to follow those same rigid rules, then there are many people at need who cannot get access to what they need, the care they need. So in that setting, they are going to potentially use more. Or I think one of the posters that we saw at ASOD was that they weren't necessarily injecting more, but their injection practices had moved away from harm reduction strategies because of the concern for shutdowns of harm reduction centers or limited access to those centers just based on the ability to keep them running. So this is a big deal. It's obviously a devastating situation. And this is, I think, where groups like SAMHSA, DEA have actually put out changes in terms of their guidance on recognizing that we can't do business as usual. And there needs to be some flexibility in what we are able to do. And I think that is something that we all need to look for in our practices, to recognize that the level of isolation right now going on for many of our fellow citizens, and in particular, many of our sickest, in our communities has been very devastating, leading to worsening mental health disease, worsening addiction because of the lack of access. So I think that is it's something we all have to think about.
Right. And so, Susanna, you're the hepatitis expert, and your patient population is more often people who inject drugs. Me being somebody who does STDs and HIV, I tend to focus on MSM populations. And so there was one study that came out pretty early on, I think in April, in AIDS and Behavior. It was Dr. Sanchez, I believe. But so they surveyed many MSM, I think approximately 1,000, and they found increased levels of anxiety and decreased quality of life in about 70%. Approximately a fifth of them had lost their job related to COVID. And really at the same time, they were actually having less sex, so fewer sexual partners, less opportunities for sex, but they weren't seeing, I think a quarter were saying that they had lost access or had decreased access to STD services for treatment and screening. And so you kind of see these numbers and you just think, wow, like this pandemic is just really having this profound impact on what we do. And I just want to highlight what you just, or kind of what I took away from what you just said, is that we as providers, I think, need to be innovative. And I've been so proud of how innovative some of my colleagues have been, and kind of some of these presentations I've seen on a national level but really on the part of patients and providers, being innovative with new models of care, but then also we as providers just being flexible, right? And if there's ways that we can decrease barriers in access for our patients, just be more flexible, less rigid, if that works, then we need to realize that and carry it forward. So even when this whole pandemic is over, I think there's so much we can learn and take with us, just in terms of the changes we make to our practices, and the stringency of guidelines and testing requirements and visits, frequent visits, and all of those things.
Yeah, no, absolutely. I was dealing with it. I answered a couple of questions. So one is the Minman study was highlighted on NatTap. Woohoo! Thanks, Jules. So anyone interested in the Minman study should be able to find it on NatTap. And then actually there was another question that Jules had about the genotypes. It's actually really interesting. As we've looked at the change in Hep C genotypes over time, we have certainly seen a shift away from 1 and into genotype 3. We have certainly heard descriptions, particularly from the global trials and those trials doing full sequencing of some novel genotypes. And I have not had any of those in my cohort in the United States. I've not seen significant reporting of those in the US. Most of those reported have been in global trials. I will tell you that for the Minman study, we have not completed sequencing yet. That sequencing is ongoing. And for the 20 people who did have failure, I think we will be able to get at whether any of those were any of those novel genotypes. But Meredith, maybe we have 5 minutes left. So thanks folks for keeping us busy with questions. These are fantastic questions. So again, our mentor, Dr. Chuck Hicks, mentioned kind of getting to this point that you just made, but maybe elaborating a bit more. Well, you both live in states where there are large non-urban populations who have limited ability to do telehealth. Suggestions for this population as regards to HCV, STI, HIV testing and management. So how do we get to these folks?
Yeah, so Louisiana has a large rural population. Even really in the setting of Louisiana, I think we had some challenges. My clinic, my HIV clinic, I had some challenges with telemedicine when we first converted to doing telemedicine, because I couldn't get in touch with patients, their phones weren't working, all that. And we kind of termed this the digital divide. And, the last thing we talked about, telemedicine is wonderful. We can now write 90-day refills. We can see patients. It's so convenient for them. They love it, love it, love it. Well, we actually lose a significant chunk of our population. And so I think we have to be very cognizant of that. I don't know that I have a kind of magic bullet solution. But I do think we have to be careful that the interventions that we apply don't kind of make these inequities or these disparities even more stark. And so I think we have to be careful. But with respect to the rural population, I will say we have rolled out teleprep in Louisiana, and we've been able to reach folks from all 9 regions of the state. And this has been a partnership with our public health. It's really been an initiative through Louisiana Public Health Department. Susanna, you mentioned again the Netflix model. We have an amazing public health department in Louisiana. We're very lucky to have that, but they have really spearheaded this great teleprep program and been able to reach patients in rural areas. So kind of taking that model, I think the STD mail-in testing kits, because we are a Medicaid expansion state, if we could find an online or mail-in platform that accepts Medicaid, I think that would be a really amazing way to reach a lot of patients for HIV, Hep C, STD testing. And then, certainly, Susanna, some of the things you mentioned with respect to hepatitis C, I mean, we are doing it here. I mean, we are treating, and it's really amazing. So I don't know, Susanna, do you have anything to add?
No, I mean, I think it's a really great question. It's a great point that when in the setting of a pandemic, it really begins to shine a light on the significant disparities. And I think we've seen this as it relates to children in school, or well, to be fair, children out of school, not having access to internet, not having access to to be able to do the things that they need to do when they're being schooled at home. And I think these are critical to ensuring that we have appropriate infrastructure. And I do think, again, it gets to thinking outside the box. So we've talked for a very long time that, you know, the concept of the patient coming to you is something that we really need to get away from. And so it gets more to us going to the patient. So I do think that we've already begun doing this in the setting of COVID to care for people with COVID going into their homes, and being able to offer, you know, home-based approaches or you know, we talk about this, we see this across the globe in terms of you know, vans or mobile units, right? I mean, I will say, no one ever likes to admit it, but the VA does some things really, really well. And I'm a VA provider, and I will say that the mobile units have been very successful within the VA. There are lots of examples of how mobile units have been very successful. And, you know, another thing that the VA has done is that they've been, you know, working in telehealth for quite some time. And in fact, we do have a lot of rural veterans. And in fact, we send them iPads. And then they send them back when their visit is over. And so there are many things that you can do, but it really is thinking outside that box. But I think when we want to be creative, we really can make these things happen.
Yeah. And so it's 5 o'clock. So I think that was a very good closing statement, Susanna. The other thing I do just want to add quickly is kind of leaving with this idea of being hopeful. But I think that you said shine the light. COVID has shown the light on so many different things, but I think one of those things is our very fragile public health infrastructure. And so I think, you know, with respect to that, with COVID, I think that really, I hope that a lot of people have seen the value of having a solid public health system, and then going forward, there will be further investment in our public health system. So that's one of my hopes. I think, you know, hopefully we've tried to say how the tough can keep going and we can persevere through all of this. These very interesting times. And again, we do know there's a light at the end of the tunnel. We just have a little bit of a ways to go before we get there. Did you want to say anything else, Susanna?
Nope, I think we can wrap up. I just want to, this has been super fun. I've really enjoyed doing this with you, Meredith, and it's great to see your face. And I thank the audience. It's been great. Lots of great questions and good dialogue. So I really appreciate everyone participating in all of this. And then also just making sure that you all know that this will be available via podcast, as Meredith already said, and there's the link right there. So thanks again.
Dr. Steinberg's note, I will be in touch. Yeah, absolutely. So thanks everyone. Thanks to Don Jacobson, Jose Francisco for organizing this, and for all the people who have attended on your Monday evening.
All right. Bye everyone.
Bye.